We'll get started. Should we follow the NCCN guidelines? I would say yes. So symptoms are extremely rare until the late course of the disease, as we know. So that's the rationale. You know, in the early 90s, PSA was adopted as a marker for prostate cancer, and as a result, we see the age-adjusted incidence, which kind of mirrors our prostate screening endeavors. So we have saved lives through the use of PSA-based prostate cancer screening, and I know I'm preaching to the choir, but it's really important to remind ourselves, since the introduction of PSA in the early 90s, we've seen a precipitous drop in the incidence of metastatic prostate cancer diagnosis. And this is compared to screening mammography. You can see that screening mammography hasn't resulted in the same degree of benefit. But at the same time, we need to recognize the challenges that Dr. Donahue pointed out, and it's really important that we as a community in urology address them. So I have to say I agree. We need to salute Dr. Crawford in his attempts at trying to refine that group of patients that we pursue screening in. Now let's look at some of the methodologic challenges that our big screening study have faced. The PLCO trial. No survival benefit to screening, but why is that? Well, compliance in the screened arm was 85%. And rates of screening in the control arm actually are a little bit higher than this 40 to 52%. So the contamination that we see is huge. So it essentially invalidates that study. Unfortunately, it was only followed for 7 years, and we know that prostate cancer outcomes take much longer to have an effect. What about the European study? Number needed to screen was 1,400, number needed to treat 48. This was the original analysis in March of 2009. Again, this study was biased to the null. Despite having a huge number of patients, all within our target age, the men screened in the screened arm were only offered a screening event every 4 years. Most of them did not receive digital rectal examinations. And the primary outcome was prostate cancer-related mortality. There was a survival benefit. The hazard ratio was 0.8. At 9 years, more men were detected with prostate cancer in the screened arm, which is not surprising. Compliance in that screened arm was only 82%. The follow-up study in March of 2012 suggested that after 11 years, the number needed to screen was 1,000, the number needed to treat 37. So that number is dropping with the increased follow-up, suggesting that we need studies to follow patients out 15 years. Now, Monique Rubel just published a paper in August looking at 19-year follow-up from the Rotterdam series of the ERSPC, suggesting that the number needed to treat is falling even below 20. So you're right. I threw this in actually while you were talking. But we've been vilified by primary care as prostate snatchers, and we've lost our voice to a certain extent. And we probably did overtreat prostate cancer and continue to do so to a certain extent. We need to listen to the primary care world and be more judicious about those men that we offer screening to, offer biopsy to, and offer treatment to. So you can see the various recommendations. The U.S. Preventative Services Task Force here in 2012, the Canadian Task Force on Preventative Health, the American College of Preventive Medicine, and most importantly, the American Association of Family Practice, who've all recommended against screening. The AUA, the American College of Physicians, and the NCCN all recommend some form of risk stratification and judicious use of prostate cancer screening. So the NCCN suggests that the risks and benefits be discussed with men between the ages of 45 and 75, and only those very healthy men above the age of 75 be offered prostate cancer screening. So it's actually pretty liberal. We cannot go back to the pre-PSA era. We need to continue screening, but we need to screen smarter. So I already presented this data to you, but when we focus on the NCCN guidelines, it's obvious. History and physical, taking that careful family history, and again, focusing on age of onset and lethal cancers. Medications, really important to document that 5-ARI use. History of prostate disease and screening, including prior PSA and biopsies. All the basics. Race, especially African American race. And history of germline genetic testing, not just in your patient, but in their family members. So, a risk stratified approach. You talked about it, Dave. Dr. Donahue, you also talked about it. I've talked about it. There are a bunch of different ways of risk stratifying our patients. I don't think that all patients deserve a PSA every year. I do think that we need to discuss the merits of PSA-based prostate cancer screening and have that individual be armed with their information in order to make an informed decision about whether they want to be screened. Because although we say the PSA is cheap, I promise I'm not going to act on a result. It is very hard to withhold yourself from that 80-year-old who's healthy, on anticoagulation for AFib, who comes in with that elevated PSA. You try to say you're not going to do anything, but all of a sudden you're doing an MRI. And he's got a PIRADS 5 lesion. So now you're forced to have that conversation with him. He says, well, I don't want to take the risk. You take him off anticoagulation. He goes on to have his biopsy. He has Gleason 3+4 disease. Have you done him a favor? You've put him in harm's way. It's really hard for us to withhold that. So here is proof in this concept of risk-adapted screening. Those men with a family history do enjoy a survival benefit in terms of prostate cancer screening. This is data from the PLCO. Unfortunately, only 7% of study participants had a family history, so we need a better job of risk stratifying patients early on. Dave talked about that PSA threshold of 1.5. I'll talk about genetic markers. We can debate that one later. So in terms of early detection, the NCCN is a little bit more, let's say, aggressive than most other recommendations. So for men with a PSA less than 1 who are aged 45 to 75, they repeat testing at 2 to 4 year intervals, 1 to 3 repeat testing at 1 to 2 year intervals, and greater than 3, they proceed with biopsy. So they don't suggest we do age stratified PSA norms. They're just recommending that for everyone between the ages of 45 and 75 that we biopsy them. It's still a bit high. That we'll end up biopsying a lot of men for this. For those men over 75, their age norm is 4. Again, many of our men over the age of 75 are going to have this PSA greater than 4. So I am supportive of the NCCN recommendations. I am a bit more cautious in terms of offering a biopsy to these men. Now, I'll end it there.